Hello, my name is Ari Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to today's webinar, Increasing Access to Specialist Expertise in Rural Maine via Virtual Curbside Consults. Today's webinar is hosted by the Northeast Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology assessment. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. The consortium is collecting success stories from organizations, patients, and providers who have benefited from telehealth with support from a telehealth resource center. Share how your TRC helped make telehealth work for you for a chance to be featured along with your organization in the consortium newsletter. And then a few tips before we get started today. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat feature for communicating issues with technology or communication access issues. Please refrain using chat to ask questions or make comments. Please note that closed captioning is available and that is located at the bottom of your screen. Today's webinar is also being recorded and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. With that, I will pass it over to Reed Plimpton, Program Manager for the Northeast Telehealth Resource Center, who will introduce our speaker for today.
Thanks, Aria. As Aria mentioned, I'm Reed Plimpton. I'm the program manager for, we call it NETRIC, the Northeast Telehealth Resource Center. We serve all of New England and New York. And if you haven't met me or my colleagues, we would certainly love to hear from you. Thrilled to be joined by Mary Butler Fleming here and letting her have a chance to share some of the awesome work that they're doing up in Maine. Mary serves as the Chief Operating Officer of Community Care Partnership of Maine. Since joining the organization back in 2018, she's held multiple roles, including serving as the organization's compliance official. She holds degrees in both public health and business from Brown University. As a Bangor native and a lifelong Mainer, she's deeply committed to advancing public health and community well-being. Recently, in 2025, she was recognized by Maine Business's 40 Under 40, and in early 2026, she completed a capstone project on implementation of artificial intelligence, or AI, in healthcare through the Harvard Medical School's executive education program, and was selected as one of, by her peers and faculty, as one of the top projects, as the top project. Mary's contributed to a number of national and regional discussions on value-based care policy and presented a number of forums across the nation and across our region. And I think it has a really powerful use case here that is serving a bunch of residents in Maine in need. And I think with that, I will turn it over to her to share some of her wisdom.
Thanks, Reed. Good afternoon, everyone. As Reed said, my name's Mary Butler Fleming. I serve as the Chief Operating Officer of Community Care Partnership in Maine, and I'm excited to be here with you all and to share a little bit about our organization's journey implementing virtual curbside consultations over the last 3 years. This initiative is something that's been really well received by primary care providers across our state, and I think the main reason for that is that it's helping to address one of rural healthcare's most pressing challenges, which is very limited access to specialist expertise. So in the next hour or so, I'll walk through how we've leveraged curbside consult technology to connect primary care providers with specialists in real time. And I'll also talk through some of the metrics that we've tracked as part of this intervention, which has improved both curbing avoidable utilization and improving patient outcomes. So I think with that, we can advance the next slide. And I've just got a couple of disclosures here. So before we begin, just want to acknowledge the funding and support that made this work possible. So this presentation was supported by awards from the Office for the Advancement of Telehealth. I personally have no conflicts of interest related to the products or services that are discussed today. And the information that I'll be sharing is for informational and educational purposes only. And just want to extend my thanks to all the colleagues on the line who are taking time out of their schedule to attend this session. Next slide. So by the end of this presentation, you will be able to accomplish for the learning objectives here. So you'll be able to understand some of the unique challenges that are facing healthcare delivery and how virtual curbside consults and similar interventions can help address critical gaps in access to specialist expertise. Second, you'll get some insight into CCPM's implementation approach and the operational model that we've used for this program. You'll also be able to evaluate the evidence-based benefits and outcomes from multiple different stakeholder perspectives. And I'll also share some strategies for sustaining and scaling these programs, which can be a challenge and is really essential for long-term success. Next slide, please. All right, so before I dive in, I just wanted to provide a little bit of context about our organization, Community Care Partnership of Maine. We are a clinically integrated network and accountable care organization with a really strong focus on public health. We're substantial in scope and have a statewide presence. So we have 22 member organizations in our network so I said 22 in total. 17 are federally qualified health centers, and 5 are community and critical access hospitals that span 163 service locations across the state. Together, the network participates in 12 different value-based payment arrangements, including the Medicare Shared Savings Program. We've generated about $100 million in gross savings in MSSP since 2016. About 350 primary care providers and the members in our network collectively serve about a quarter of the state's population on an annual basis. So pretty significant presence across the state. So as an organization, we are primarily focused on implementing and scaling innovative care delivery models that improve patient outcomes and focus on effective cost management. And the virtual curbside consults that I'll talk about today are one example of that approach in action. So, next slide. So to understand why the virtual curbside consult model has been so impactful for us, we first need to understand, Maine's unique healthcare landscape. So Maine is both the oldest and the most rural state in the nation. So about a quarter of our population is over the age of 65, and more than 60% of our residents live in rural areas. And we are facing a really dire lack of access to specialists, particularly cardiologists, rheumatologists, endocrinologists in particular. And wait times routinely exceed 9 to 12 months for those specialties in particular. Additionally, much of our clinician workforce consists of new to practice nurse practitioners and physician assistants who are sometimes working without a medical director on site. And unlike a lot of the large health systems, our network is comprised of mostly primary care focused, federally qualified health centers. So they don't always have co-located specialist colleagues that they can do, quick hallway consults with. So these factors create challenging circumstances for both of our providers and our patients. When we know, and it's well documented in the literature, that when there's not enough access to meet demand for specialist care is delayed, which has pretty substantial negative impacts, not only on total cost of care, but more importantly on care quality and health outcomes. So that brings us pretty well into our next slide. So the approach. So what exactly are these curbside consults that I keep mentioning? So they are real-time, secure digital interactions that connect primary care providers directly with specialists through a mobile app, a laptop, or an EMR interface. So the platform we used is called Picasso MD. Providers get access to a specialist within 30 seconds. So in CCPM's case, our data says about 14 seconds for a PCP to connect with a specialist. And they're able to engage in a synchronous dialogue and get actionable guidance and recommendations right on the spot to help them resolve challenging cases. So when I describe the interface, it's a lot like getting on a rideshare app, like an Uber or Lyft, believe it or not. So you could select the specialist that you'd like to consult with, and in seconds, you're pulled into a synchronous HIPAA-compliant messaging platform. You have the ability to send photos, to do voice to text transcription, It's intuitive, it's pretty easy to use, and the providers have really loved it. Um, for our pilot with Picasso MD, as you saw on the previous slide describing CCPM, we've got quite a few sites, and so we wanted to narrow in our focus for who we should start with first. So we focused first on our ultra rural sites. We have some FUHCs that are located, on a little literal island, an hour or so ferry ride away from the mainland. So we focus on sites like that, practices that had a high proportion of new to practice NPs and PAs, sites without co-located specialists, and sites without co-located medical directors. So those were the priority sites for the first phase of the intervention. We do tend to see, 3 years into this work, that NPs and PAs are using the tool at about a rate of 2x. The medical directors, or MDs and DOs rather, and the utilization of the tool does tend to be higher. Medical director on site. In terms of the use cases for providers using the tool, many of them are using the tool at the point of care. So when they're contemplating whether to send a patient to the emergency department or refer when they're using it.
Sorry about that. Looks like my internet cut off. I'm restarting
That's
this.
okay. I think we can go right into the next one. All right, perfect. So, getting into the benefits of this model, they're really extensive and sort of multi-stakeholder benefits. So, for patients, we're seeing improved access to specialist expertise. Patients don't have to leave their community, which is huge in rural Maine, where going to a specialist visit means, driving 2 to 3 hours each way and often incurring some significant out-of-pocket costs. Patients are getting faster diagnoses, more optimized therapy. Obviously, this translates into improved health outcomes and enhanced patient safety. And then from a cost perspective, we're seeing significant improvements in avoidable referrals and emergency department visits. So I'll share a little bit about that later, which of course has significant, financial implications, particularly in a value-based care model. And then importantly, the providers, the PCPs are maintaining their central role in the care coordination, which we feel is really important. So this isn't about replacing PCPs, it's about empowering them with specialist expertise when they need it the most. So I would say those are some of the main benefits of this intervention. So, the next slide, who benefits from a model like this? So, when we map out all the different stakeholders who benefit from curbside consults, the ecosystem is really remarkably broad. So, obviously, patients and their caregivers benefit directly. Primary care providers gain confidence and expertise. ACOs like CCPM that are in value-based payment arrangements, our member organizations, hospitals and health centers, health insurance payers, health adjacent entities, even state and federal governments benefit through reduced Medicare and Medicaid spending and, overall population health. And specialists on and off the platform benefits. So, when I say specialists off the platform benefit, I mean the cases that they are seeing are sort of screened out if they're unnecessary by that curbside consult, and they're more appropriately worked up if they are indicated. They're getting guidance. The PCPs are getting guidance on what needs to be done in advance of the specialist visit to make it most efficient and effective. So specialists are benefiting as well. So when I get into the numbers, I think they really tell the story on this next slide here, and they speak to some of the compelling outcomes. So since October of 2023, we now have 100% utilization across the 22 CCPM member organizations. So there are well over 300 primary care providers across the state using the tool at this point. We've completed over 5,700 consultations in that time frame. And our provider satisfaction rate is pretty darn close to 100%, which is really extraordinary. Then from a financial perspective, we've generated about 1.25 million in estimated cost savings through avoided utilization. And this is largely attributed to avoiding about 2,000 unnecessary specialist referrals and about 168 emergency department visits. So, all those metrics and numbers are great, but I really like the testimonials on the right-hand side, which um, are from two of our clinicians across the network. So, Dr. Megan Brewer, who practices in the greater Portland area in Maine, said that it is really not an exaggeration that this tool has saved patient lives. And importantly, you can see that they feel a renewed sense of joy, and that this is being used broadly as a recruitment and retention strategy for a lot of our FQHCs and hospital members. So transitioning to the next slide here, I pulled some more data, just gives you a little bit of insight into the different specialties that are offered. I think it's about over 30 specialties offered on the platform at this point. And you can also see the consult volume by specialty of CCPM's providers over the last several years. So sort of intuitive finding here, which is that the specialties that have the highest volume of consults correlate directly with what we're seeing as the longest wait times for specialties. So it's been a game changer for PCPs to be able to consult with these specialists in real time without having to, send their patient into a 9+ month queue. So some helpful information there. On the next slide, I'll talk a little bit about some outcomes overall. So have achieved, some significant milestones over the last few years in terms of program sustainability and growth. So as I said a couple of slides prior, we now have statewide utilization. 100% of our members now have providers using the tool. Another thing that I get a lot for questions when I give presentations on this topic is who pays for this? So this is not something that the patient pays for out of pocket. It is free to the patient. So at the beginning of this intervention, CCPM had an arrangement where we were paying per consult for our members. And then we were successful in demonstrating the value of this tool to our payers. So we now have several payers that we have value-based payment arrangements with who are covering the cost of this service for their patients. And what we have not been able to cover with payer support, we have gotten grants to cover. So there is no cost to patients and there is no cost to our members in our network. And that's something that we're really proud of. Another thing that we're really proud of is that this project has really been a springboard for additional collaboration opportunities to bring more specialist expertise into the state of Maine. And so this momentum is something that's, translated directly into expanded partnerships and new initiatives, which I want to talk about on the next slide. So looking ahead to 2026, new and expanded directions for this work. The first thing that we're doing is we are working on establishing longitudinal collaborations between PCPs and specialists on the platform. We know that sometimes one curbside consult doesn't do it, particularly for patients with high-risk chronic conditions, and having a sense of continuity in those conversations between the PCP and the specialist can be important. So that's one thing that we're building capacity to be able to do. The second thing that we're doing is we're proactively identifying high risk and or suboptimally managed patients for targeted short-term specialist input rather than waiting for the PCPs to engage in a consult. And then as a clinically integrated network, the other thing that we do have is EMR access across our membership, as well as access to a statewide health information exchange. So we're able to proactively identify and tee up the pertinent details of cases for review, almost like a sort of a mini me-consult in a way. And like many organizations, we're thinking a lot about how to responsibly and effectively integrate artificial intelligence or AI into our work. And of course, this extends into the Curbside Consult initiative. So we're exploring how to potentially integrate AI clinical decision support tools into the workflow in order to reduce lower acuity specialist consults. And then concurrently to that, we're working to develop clinical decision support tools to help sort of optimize timely appropriate and prioritize specialist referrals. So that's work that we're doing as well. And then last but certainly not least, we're working with Picasso MD to hopefully pilot direct telehealth visits via Picasso MD later this year for some of the highest demand specialties. So those involved in healthcare operations know this is no small task. There's licensing and credentialing, network status with the payers, all that fun stuff. But it's certainly an exciting proposition that could have a really meaningful impact on access in our state. So we're looking forward to continuing to build and plan towards that in the coming months. So that's what's planned for the year ahead. So I think I'm close to the end on my slides. So really appreciate everyone's time. I know I wasn't even close to the hour, so we've got a lot of time for questions, but really appreciate everyone taking the time to be here. I hope it's given you some, practical insights about how this has worked for our organization. And I put my email towards the bottom if you have questions or would like to, discuss further. I'm happy to connect.
That was awesome. Thank you, Mary. Yeah, I think to Mary's point, whether we have plenty of time for conversation here. We definitely I've done presentations with Mary before. I think we both enjoy it when it's a little interactive. Um, so please feel free to put questions in the Q&A, and we can revisit slides if folks need things like that. We do have a couple of questions coming in here, Mary, and I will tackle them as they come in. I'll share them with you. I'll delegate that so you can just think about the answers. So as a reminder, we do have the Q&A function. I'm going to start with the question that came in the chat because I think it's easier for everybody. I can mark whether or not we're answering them live in the Q&A and everything else. So first question, does your work also support inpatient or acute specialist needs? You're muted, Mary.
Sorry about that. That's a good question. So right now, the tool is exclusively used in the outpatient setting.
Yes, I will tack on there is that's something that's sort of in the long-term strategic plan for you guys to consider those other settings, or do you think that you'll stick primarily to the outpatient based off current utilization and need of your members?
I think there's certainly a use case for the inpatient setting. Because of our membership composition, we're mostly FQHCs. So we've got, some hospital presence, but only 5 out of the 22 are hospitals. So really what we found the most pressing need was in the office visit setting, and that's why we focus on, the outpatient side of things. I think if we were to design the intervention for the inpatient setting, the metrics would be different. But I think it's something we've talked a little bit about and something I think we would certainly be open to exploring in the future.
Sure. Thanks. All right, now we have some questions coming in. So I'm going to start at the top here. Is behavioral health included in the options for specialist referrals?
Yes, it is.
And how, so do you have anything else you want to add there? Do you want to move on to the next one?
No, short. I'll keep it short and sweet. Yeah.
Deal. How are your specialty providers credentialed with the FQHCs, or does that work? Is that part of the credentialing goes through you guys, or can you talk a little bit more about that process?
Yeah, so they're not credentialed through the FQHCs. That's something that's managed all by Picasso MD. So that's not something that we're directly involved in. And because they're not billing from the FQHC either, it's less of a concern. 'Cause it's
Sure.
a PCP to specialist interaction, if that makes sense.
Sure. I think this question may be very similar in your answer, but who covers the malpractice insurance for these consults?
Yeah, that's a really good question. It's something that we explored extensively when we were thinking about um, using this tool. And so it's the way I frame it in my head is very similar to if a PCP did a hallway curbside consult with a specialist, right? Hey, I've got this patient, not quite sure how to manage it. What would you recommend? the specialist gives their input as part of the hallway consult, and then the PCP ultimately decides the plan of care. So the liability, the malpractice, et cetera, that still rests with the PCP. So it's not absorbed by the specialist on the platform, if that makes sense.
Sure, it does, and I'm glad it came up because it was the opposite of what I expected. So no, that did
Yeah.
done to me. Um, I think you touched on this in your presentation, but could you talk a little bit about the time lag between the consult request and the specialty provider availability? Does that
Yep.
differ by provider type, so on and so forth?
Yep, that's a good question. The average is from when you click, I would like to talk to a cardiologist, the first available cardiologist. It's about 14 seconds to when the chat pops up on average for our data. For Picasso MD nationally, they say closer to 30, but of the 5,700 or so that we have done, we found in about 14 seconds is the average for the PCP to get connected to the exchange with the specialist.
Incredibly fast. Sorry, I was hoping the dog would stop barking by the time I
That's
unmuted.
okay.
Out of curiosity to tack on to that, what does it look like for the provider? Is it on their laptop where they're likely already taking notes, or is it on a secondary device?
That's a good question. There are a couple of different options. There's a mobile app that they can use, and there's a web-based version, and then there are different levels of integration with some EMRs. So some EMRs, they have a Picasso MD, button that they can press and initiate the consult. In the cases where there is EMR integration, it's convenient because the transcript can get automatically stored as part of the patient record. That's another thing that I get asked about a lot is like, how are you documenting the transcript and pulling that in? There's a couple of different ways that we do it. For the members that have I should preface my answer by saying all the different members have different EMRs and different instances of their EMRs. So it makes things a little bit complicated. For the members that have an EMR that's integrated with Picasso MD, that transcript being part of the patient record happens, automatically behind the scenes. For organizations that are using the web-based version or the mobile version, we have coordinated workflows with the quality teams of each of the member organizations, and they're batch uploading the transcripts to the patient health records on a cadence, whether it's biweekly, monthly. We set that up with each of our practices. So it's not a perfect workflow, but that's what we're doing for now to have the transcript part of the record. And we advise providers to just document and reference that they had a curbside consult via Picasso MD. And so that's generally what they're doing in their documentation.
You kind of just took two questions right out of the chat there. It's
Oh,
per
good. Okay.
thank you. Yeah, EHR integration was one, and then documentation was one as well. And so, I mean, now that you know that those were also questions that were asked, do you have anything else to add? I feel like that was a pretty thorough.
No, no, nothing to add. But if people have more specific questions, I'm happy to answer it.
Yeah, I think I'm glad the way this is working out is great. There are definitely still questions coming in. Is there any PHI exchanged during the consult?
There, the way we've designed it, you can customize it. What we did is, so the short answer is yes, there is PHI shared. Name and date of birth are shared to go into the consult. No insurance information is shared because we didn't want to bog down the providers. We wanted to make it like as easy as possible and as frictionless as possible for them to initiate the consultation with a specialist. So they just put in name and date of birth, and we have, all of the necessary protections and agreements in place with Picasso MD for us to be able to share data in that way. And then what we do on the back end is we have centralized quality staff that can identify that patient to a particular payer or health plan. So we know, how many are Anthem versus Medicare, et cetera. And we collect that data and use it to advocate to the payers for cost coverage for the service. But it's just name and date of birth that go into the inquiry.
Sure. Thank you. I feel bad because I won't tack on this time because there are a lot of questions coming in, but I am
It's
curious
okay.
about how some of those conversations go with the payers. If we have time, we can revisit. I appreciate the familiarity with Maine. In this next question, can you talk a little bit about your utilization dispersal across the state? Is it primarily in the locales, the cities like Bangor, Portland, maybe Augusta or Lewiston, or are you seeing reach as far as Machias or Caribou?
Yeah, there's a slide that has a map with like these little bubbles on it, blue bubbles. I can't remember what slide it is, but we can pull the slides back up. It's actually like I don't know the name of the graph, but it shows you the
It's like a
utilization
heat
by
map.
volume.
Yeah.
Yeah,
All right. If you are able to, it is slide 11.
thanks, Reed. I'll speak to it while it's being pulled up. There's utilization across the state. What we tend to see drives utilization of the consult is not so much the geography of the PCP seeking the consultation, but the characteristics of the PCP and the practice in which they are providing care. So if they are an NP or PA, they're more likely to use the tool. If they're operating in a practice without a medical director on site, they are more likely to seek out the consultation. If they are operating in a practice that doesn't have specialties, um, more likely to seek a consultation. And then we see payer mix informing the work a little bit as well. So you can see the biggest blue dot in like central Maine, that's the greater Bangor area. I think that that's probably just a product of that's where our largest member site, our largest hospital member is sitting. So most PCPs on the tool. So I think there's a number of factors, but everybody's using it. I would say those are the factors that drive the variance in utilization, if that helps.
Sure. Yeah, no, and I think the map is really helpful for those that maybe are less familiar with Maine. Down in the bottom there, the bottom left corner, you can get from that corner of Maine to New York City faster than you can get from that corner of Maine to the top right bubbles there. It is a tall state.
Yeah.
Um,
And Reed, people who aren't familiar with Maine might be wondering why like the upper left is no dots, and it's because like literally no one lives there.
yeah,
Like it's just trees. So
trees and
yeah.
moose.
Yeah.
Yeah, no, thank you. Yeah, so hopefully that's helpful context for some folks. I do so I'm gonna hop a little bit out of order here and get some of the quick answers out of the way so you have time to dive into some of these more intricate questions.
Sure.
The specialty providers, are they employees of Picasso MD, or are they also working at health systems throughout the state throughout the nation?
I think it's a mixed bag. I know a lot of them are also employed by other organizations. So they're, practicing cardiologists at a, large health system, and they can sort of pick when they're on and available on the platform. So they can do it supplementally to a full-time job. It's my understanding that many of them are doing that.
Sure. Okay. Um, Back to behavioral health here for a second. It was the not clear on in our it's the slide right above this with the pie chart. Uh, it was not necessarily clear to one participant where behavioral health is fitting on your volume by specialty. Is it in the other section? Is the first part of the question, and then any thoughts you have on why maybe that is a lower utilization, knowing the very real need for behavioral mental health services across Maine and across the nation.
Yeah, I think it's fitting in the other. Um, I think behavioral health is a newer specialty that they brought onto the platform, and this pie chart is reflective of like all time utilization. So it could be just that, if it's newer and these other specialties have had, 3 years worth of data, and the behavioral health is newer, it could be crowding it out because I do agree with you. It's definitely a need. I will say a lot of the FQHCs in our membership offer pretty comprehensive care at their site. So many of them have integrated behavioral health, co-located with primary care oftentimes. So I think that may be why you're seeing lower than anticipated consult volume. Again, just a product of the unique membership composition of RCIN.
Sure. Yeah, no, that makes sense. Um, Abraham, if you don't mind, I'm just looking through the questions here. You had a question about acronyms, and I am often guilty of doing acronym soup. Could you just throw another question in there that highlights the specific ones you want us to thoroughly explain? Um, Mary, back to you. I two different questions on the referral realities. Uh, First one, are providers kind of randomly assigned to the first specialist in that care avenue, or are they able to, kind of establish a rapport with the specialist and request that specialist the next time they need?
That's a
Uh,
really good question. The default is first available, and providers can set preferences. So, say I was a PCP read and you were a cardiologist, and we had a really great interaction. You were really helpful to me. I can set my preference to say anytime Reed is on the platform and accepting consults, go to him first before anybody else. So it defaults to the first available, but you can customize your preferences.
Very cool. Okay. Yeah, no, and I mean it also is great that you're not stuck if like in that scenario if I'm not available, it's gonna immediately try to patch you with somebody else is sort of the way I'm understanding it.
Yep, yep. So sort of preference-based algorithm. Yep.
Um, from your experience and from the work that you're currently doing, what percentage of like traditional referrals for specialties that are currently considered under e-consults could be achieved through this more virtual curbside consult type encounter that you're utilizing?
Ooh, that's a hard one. I don't know if I'd be able to assign a percentage to it, but I would say a significant percentage of the referrals that go through to specialists right now are unnecessary. One of the nice things about the Picasso MD tool is when a PCP opens up the consult, it asks you, what was your plan going into this case? Were you going to manage in the primary care setting, refer to a specialist, and or go to the ED, right? Those are the three options. And then it asks you that same question at the conclusion of the consult. So how we get that cost savings estimate and the counts of the avoidable referrals to specialists is by tracking that pre-post data. And so I'd have to go back and look at our data to see how many PCPs went in with the intent to refer to a specialist um, versus afterwards. I know we've avoided about 2,000, but I don't know what percentage of the total referrals that would represent.
Sure.
My friend is a pulmonologist. He practices in Bangor, and he said his patients that he sees follow a rule of thirds. One third probably don't need to be seen by him, could be managed in the primary care setting. One third probably do need to be seen, but they're not worked up appropriately. So something else, labs, imaging, something else needs to be done for to have an effective visit. And then one third are clinically indicated and ready. So I think there's probably some ebb and flow by specialty, but I think his adage is probably not all that far off. So
Sure. Yeah, no, that is interesting. And I mean the other kind of pro, if you will, for this encounter, depending on how you're doing your e-consult, is just the timeliness, right? Like a lot of e-consult models utilize like a 24-hour response rate or things of that nature, as opposed to getting it in real time while the patient's still directly in front of you. Right.
yes, exactly. That was something that we had conversations about early on and thinking about piloting this intervention was like, oh, well, like a lot of our members are already using e-consults. And our with the conclusion that we came to relatively quickly is like these are differentiated use cases and there's space for both of those tools because there are many things that are maybe too complicated. There's too much complex medical history. It would not be appropriate for a curbside consult, right? You can only distill so much information into this synchronous chat. That may be one if you can be patient for, the day or so. A curbside consult or an e-consult rather would be more appropriate versus like, I'm gonna send this patient to the ED right now unless I get, advice otherwise. And, an e-consult's not gonna help you there. So we did a lot of education with our medical directors across the network on like what are the differentiated use cases for the different tools in your toolbox, whether it's an e-consult, curbside consult, or otherwise. So I think that that helped people decide which tool they were going to seek out.
Sure. Yeah, that's really helpful. So you just touched on, I'm really going out of order here, but you just touched on a question that was asked that I'm going to paraphrase slightly on, but if the consult, results in them suggesting that they are in need of an in-person specialty care, right? So you just referenced pulmonologist, maybe they need to go get some workups done. Um, is there any sort of communication around severity or timeline of that visit? Like, do they need to go to the emergency department right now? I agree with you. Versus, yeah, they can be on a waiting list, and this can happen anywhere from unfortunately 2 to 6 months later, type of deal, right?
Yeah, we're working on that second piece, the like prioritization and urgency, etc. That's something that we're working on in 2026. Right now, the specialists can one-off advise, right? Like, here's what should be done in advance of the visit. Here's, the level of urgency. And we have anecdotally found that if PCPs include information in the referral note, that they have consulted with another cardiologist or pulmonologist, and this is the recommendation that they got that they send it through. They've been getting less pushback on taking the referral. So I think that that's that another colleague has served as sort of a gatekeeper and has vetted the case. I think helps a little bit. At least that's what we're hearing anecdotally.
Sure. Yeah, you've done your homework before you made the referral, right? Type of thought
Right.
process.
Right.
Um, here's a relatively lighter lift than the last couple.
Sure.
Uh, is there any video or audio video encounters possible within the platform within Picasso MD that you're using now, or is it all text based?
It's all text-based. You can do voice to text, which a lot of providers like because that's like a lot to, type out. So it does have that functionality. No audio visual right now, but I think that's something they're building towards as part of the infrastructure build out to be able to offer direct patient to specialist visits. But my understanding is not at present.
Sure. Okay. Yeah, that's helpful. Um, Are the specialty providers that are serving the Maine sites specifically from Maine, other states, across the nation? Do you have any international providers that you know of that are serving?
To my knowledge, they're all US based. Some of them are located in Maine, but that is not necessary to go onto the tool. So some are in Maine, not all. Many of them are from across the country.
Sure. And then they work with the vendor to deal with licensure considerations, things like that.
Exactly. Yeah, the vendor is vetting all of that credentials and licensing, etc., to bring them onto the tool.
Um, who is the covered HIPAA entity in this model?
So that's Picasso MD. So CCPM is a business associate of the covered entities, which are our members.
Great. Thank you. Um, How are the fees structured for the consults? And I know this is a little bit different for you than if like a health system took it on independently, right? It's a part of the ACO model and the collaborative, the membership model that you have. But could you talk a little bit about that? How are the fees structured? Is it per encounter, by
Yep.
specialist, by amount
We
of
pay
time?
we pay per consult, and we get like a volume discount and a nonprofit discount as part of the work, and then anything that is paid for by the payers for their patients, they contract and negotiate directly with Picasso MD. We don't step into that. We
Oh,
basically
really?
advocate for them to cover the service for their patients. We articulate the value to them as a payer. We show them the data, right? This is how many of your patients we have provided the service for. This is how many ED visits have been avoided. This is the cost savings to you. And then we do the warm handoff and they negotiate. So we've done that 3 times successfully now. Um, and for our case, we pay, like I said, per consult with a not nonprofit and volume discount, and then we pay under a master services agreement. So the ACO or CIN holds the relationship with Picasso MD, and then any member of our network can get access to the platform for free.
That's great. Yeah, and so just to be crystal clear, you're not limited by the amount of back and forth encounters, if you will, between in a singular consult. The consult's not time limited or question limited or anything like that.
No, they're typically like 3 to 7 minutes long, depends on how complicated they are. But we pay like per consult, no matter how long or short they are, or the type of specialty they are, or anything like that.
Okay, that's great. Thank you. Um, you talked a little bit about the quality team involvement, both between
Yep.
you and your member sites, and I'm imagining some of this falls in there. But how are you ensuring the specialist information they're providing is, up to date with the newest guidelines or the newest expertise that's available in their topic?
Yeah, that's a really good question. So our medical director does like batch reviews. So we have access to all of the transcripts on a centralized database. So our medical director oversees, reviewing them for accuracy. The provider satisfaction score gives us an indication as well, like if there was a satisfactory response. And then Picasso MD also has a QA, QI process for evaluating the transcripts. So we're sort of doing it on both sides of the relationship.
That's great.
Yep.
Um, so this next one's kind of a multi-parter, and
Okay.
I'll pause in the middle of it, but I want to read it verbatim because I think the perspective on it is important.
Mhm.
So coming from the patient kind of perspective, but obviously a healthcare professional that's interested enough to join us this afternoon. Um, Based on my recent experience with specialist care, I have the impression that they don't talk to each other all that often, and they're not usually treating me as much as they're treating my insert thing here, right? Like joint pain or degenerative joint disease or something like that. Do you think bringing the specialist into a consult with the primary care clinician who already has an established relationship with the patient has the potential to move the needle there, right? And to be done and have the specialist consult be done more in that manner of like, I understand you as a person and less of you as the
Yeah.
patient.
Absolutely. Yeah, I like that comment, and I think that's a benefit we haven't like overtly captured, but I think that's huge. Because it brings to life the details of the patient's experience, and it centers the patient in the interaction between the PCP and the specialist. So yeah, I think that's certainly true.
So the second half of that is kind of like
Mhm.
flipping the script on it, right? There are
Yep.
a number of Americans who do, right, especially in rural areas, who do not have a PCP and really only show up to health systems with either an emergent issue or are already in there because of some sort of long-term chronic condition. And so there are think pieces and articles about the possibility of using this specialist as a conduit to more continuous care, right, as a conduit
Mhm.
to the primary care model. Do you have any thoughts on that?
Hmm. I don't know that I've thought about it all that much that way, to be completely honest with you. I know that some of our sites have walk-in care. So they've used the tool to do a consultation for patients that are not established primary care patients, like they're walk-in care patients. Um, but yeah, I think any opportunity to engage a patient that for, any number of reasons, they're not intimately connected to primary care, any opportunity to get that feedback and to engage them is wonderful. So yeah, I like that.
Sure. No, that's great. And so this next question kind of spawned out of the conversation we were just having.
Sure.
The consult itself, is it provider to provider only, or is the patient kind of involved in the conversation with the PCP being like the medium?
It is strictly speaking PCP to specialist. There is no direct patient interaction with the specialist. I know that many PCPs will be transparent and forthcoming with their patient, right? So I've seen it demonstrated like, you know, it would be about 9 months for you, Reed, to see a dermatologist, but I actually have access to one on this platform. Would you mind, and they'll get verbal permission, would you mind if I, took a picture of the rash or whatever it is and sent it to one of my dermatologist colleagues? And so they'll be able to send the PCP, they'll be able to see the PCP send the photo and type, and so they can kind of see the interaction going on, especially within the office, but they're not like explicitly invited into the actual interaction between the PCP and the specialist, if that makes sense. But they are consenting to it and aware that it's going on if it's happening at the point of care.
Sure, but no, and that makes sense, right? They know it's happening, they understand the reason for it, but they can't necessarily be like, oh, can you also ask this follow-up
Right.
question? Um,
Right.
okay, no, that's great. I I appreciate you working through all those with me. I'm looking just to make sure. I think we made it through. Oh, I missed one that went into the chat. Are you using any monitoring devices within this workflow and the system that you've developed? And if so, how does that data interact with the specialist, right? Like if it's a blood pressure monitoring kit, and you have all of this information, is there any integration there? Are you doing any of that?
That's a great question because the consultation is by definition like kind of episodic, right? And as needed. I could see the consult interacting with like RPM data insofar as the provider sees something unusual or concerning in the RPM data and that sparks them to request consultation about what they're seeing, but it's not integrated in the sense that like it's there's an automatic outreach if something flags on
Right.
our
If there's a red
data, if
flag,
that makes
all of a
sense.
sudden the
Yeah.
Costco MD's like, let me in. Yeah, okay, sure. Again, yeah, I mean, thank you. It was a great presentation. I really enjoyed this kind of Q&A back and forth. Kind of feel like we did a little podcast here
I know,
with
it was nice. A lot
with
of
some
questions.
fan seated questions. Yeah, and I mean, we do have a few minutes before I want to turn it back over to Aria to give the spiel about the upcoming NCTRC events. So if anybody else has anything else, feel free to pop it in. Monitoring both here, but otherwise, yeah, Mary, really can't thank you enough. That was so informative, and always appreciate you being so willing to share the data that you have as well.
Yeah, of course. Thanks for having me. Appreciate it.
I think I'm not good at this new 8 second echo pause. I'm still trying to get my 5 seconds underneath me, but I think we are all set here. Ari, if you want to sort of do the wrap up spiel and close this out. And yeah, thank you all. That's the last thing I'll say. Thank you all for taking time out of your day to join us and providing these questions so that we can get this back and forth and we can all go through this period of learning. And thank you again, Mary.
Thank you, Mary, and thank you, Reed. Just a reminder that our next webinar will be held on Thursday, April 16th. That webinar will be hosted by the Northwest Regional Telehealth Resource Center, and it will focus on data interoperability, what's changing, what it means, and how to prepare. Registration information is available on the NCTRC events page. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Um, we also have another survey, as I mentioned, where you can share your telehealth success story for a chance to have it and your organization featured in our monthly newsletter that is distributed to our national audience. Your feedback is very valuable to us. Thank you again to the Northeast Telehealth Resource Center for hosting today's webinar, and thank you to Mary for her presentation today. Have a great day, everyone. Goodbye.